Hi, I'm Dr. Gerald Deas. Welcome to Health Center from Downstate Medical Center. Today we're going to talk about something that everybody has, or should have, hopefully has, and that's a hand. You ever see that expression, lend a hand? Well, I'm telling you, when you need to have somebody lend a hand, that means that, depending upon you, to have two hands, you know, and of course, we have difficulty in using our hands sometimes. I particularly, people, when I went into medicine, they would say, well, how could you go into medicine when you have such large hands? Especially for surgery or anything to do. I said, we don't operate with our hands, we operate with instruments. You know, our hand is only extended of the instrument as such. But the hand's such an important thing. You can't imagine all the things that folks, the only thing that separates us from the ape is the approximation of two fingers, like this. These two fingers. If the ape had that, he could do what we're doing, you know, but he can't do it. And so, of course, we can't even train him to do it because he has this kind of hand. The thing is that people do have hands that become not capable of performing the things that they do daily. Just think, just example, going to the bathroom. Just going to the bathroom takes hands to cleanse yourself and things like this. Or just pick up a fork, try to eat or something with fingers that can't go like this, or can't even go like this because of rheumatoid arthritis and other arthritides that can affect the bones in the hand. Today we're going to come in to hopefully help you, those who might be sitting out there that can't do dependent living, to do independent living. When you can't use your hands, you are dependent upon people. Well, there are even certain things that we have made, like forks and knives and scissors and all the kind of things that are, if you can do that a little bit, you can actually make the hand functional. But there's even other things like surgery and things like this that can make a difference in the use of the hand. Well, we have a hand specialist, been here at Downstate Medical Center. He sits shorter than I have, but I don't know. I think we both could run that race right now, but whatever it is, I'm going to introduce you to him because he is the hand man. So I want to welcome you, Dr. Gordon, Stanley Gordon. Yes, having you to be sitting here this morning with all the things that we both have gone through. Wars and all the other things, and revolutions, marches, and all the kind of things. And the hand has marched on also from being not perfect, but imperfect to perfection. But let's get just a little bit of background so our audience will know just who's sitting here in this wonderful chair here.
Well, thank you very much, Dr. Deas, for your generous comments and for the privilege of sitting with you here. I guess neither of us wants to admit exactly how long we've been here, but it's been a while.
Sure.
Both gray around the temples and some other places too.
A little less hair too.
Yeah, as Dr. Deas mentioned, I've been involved with orthopedic surgery for more than 40 years. I trained in the late 60s, so that's going on 45 years now that I've been doing this business. I do mainly hand surgery. That's been my major interest, although I have been involved in many other aspects of orthopedic surgery at times, including orthopedic trauma and joint replacement. And over the years has been a dramatic, and I would have to say that adjective twice, dramatic changes in the kinds of things that we can do, the kinds of things that we can offer to patients, the kinds of services. Excuse me. Orthopedics is a field in hand surgery too that can very much affect the quality of life. Sure. Unlike some of the medical fields, which are really focused on almost life or death issues quite often,
sure,
if not immediate life or death, long-term life or death issues. Orthopedics often, but not always, focuses on improving quality of life. Now, if you have an acute traumatic situation, a tragic auto accident or something like that, there are life or death issues there. But generally, there's a lot of surgeons participating in the resuscitation, and then we get involved in the reconstruction of all these injured extremities. So it's a fascinating field. It's of great interest, and I think of increasing interest as our population ages and the demographics indicate that we are going to have increasing elderly who demand, and in my opinion, and I'm sure you used to, have the right to a lot more independence and dignity than they did have when you and I started treating. I mean, it was patients back in the 50s and 60s that patients who had certain kinds of fractures or injuries were confined to wheelchairs or the home, couldn't get out to their families, couldn't get out to visit. They used to have a word called shut-ins, and there were many of those at that time. People nowadays who can get out and enjoy life, and more than that, they can contribute in an economic way, contribute in an educational way, contribute even in child care for a family member who has to go out and earn a living.
Definitely.
And medicine and orthopedics can very much assist in those things. In your comments about the hand, which are germane and pertinent, and I feel realistic, there's another aspect of it that is not often widely appreciated, and I would bring that up to add to the discussion, is that the hand is one of the most important cosmetic aspects of the body. People don't realize that very much, but when you look at, I look at Dr. Gerald Deas across from me, what I see is his face and his hands.
Yes, right, sure.
And people are very sensitive about the way their hands look, the way they're shown on television. You made the comment that someone noticed that you have large hands.
Right.
Well, they don't necessarily notice that you have large knees or large shoulders. Those are covered. So we have to take that very much into consideration, particularly with young women, that what we end up with has to be as functional as it can be, but we can't make large compromises in the appearance. Otherwise, this individual, he or she as the case may be, will be very sensitive about it. And there have been many cases that have been shown where you end up with a result where the individual can grasp, as you said, or pinch or something like that, but they are so ashamed of the appearance of this hand, even though it has function, that they don't use it. So that it's used in as a demonstration for educational purposes, but it doesn't help with activities of daily living.
When you mention something like that, you pass the hand salons now where women sit every weekend. They're more than barbershops, they're nail salons, and they're getting their nails painted, and they're getting their hands massaged, you know, and they feel so good when they get. In fact, my wife said to me one time, "Why don't you go and have your hands massaged?" Well, I said, "Well, I do. I massage my hands all the time,
and in a lot less expensive way."
That's right. But I don't need the shiny nails, you know, which some men are even going out for shiny nails, you know.
Absolutely, yes.
So continue. I'm sorry to break it to you.
To continue, just about some of the advances that have been made in the upper extremity. Most hand surgeons do upper extremity work from the shoulder to the fingers. So it's not just the areas of that are below the wrist. There's been a lot of joint replacement, which it started, as you're aware, in the 60s in the hip due to some pioneering work by Dr. Charnley in Britain and some others. And then it spread to the knees, and more recently to the ankles, and there's a lot of joint replacement done in the shoulder and the elbow, to some extent in the wrist. In the hand, under certain circumstances and certain people with certain problems, joint replacement can help alleviate certain deformities, certain dysfunction, and improve appearance too, which is consonant with the comments that I made earlier. So that has been a major area of advance. Now, a lot of the surgical procedures, particularly in the shoulder, but also in the elbow and the wrist, are done arthroscopically. What that means, to elaborate a little bit more, is that these procedures are done through very minimal incisions, just small knife stab wounds that you can barely see later on. And we have a lot of technical devices, fiber optics, cameras that allow us to operate through these very, very tiny incisions and do a lot of things to help a lot of people. People who need for activities, athletes who are demanding the highest levels of performance in a competitive level. Some of the surgery is done arthroscopically to assist them in this. In the upper extremity, advances that began really in the late 60s when I became involved in this field involved some of the tendon repairs and reconstructions that have been done for injuries, lacerations. You know, the hand is very, very, very complex anatomically. Well, you go ahead. I'm sorry.
That's okay. No, you're the expert on this. I just want to bring up as you're talking, so I won't forget it. You know, so many times in rheumatoid arthritis, you get this hand bent out this way. Now, there's no way you're going to function with that hand in arthritis. That way, if you try massaging it or what have you, because there's certain anatomical things that take place that are irreversible by doing certain exercises. Not that it can't help, but sometimes if you want to bring that hand back so you can clap, it's hard to clap this way.
Well, but applause is one thing, but with the hand deviated, we use the term ulnar deviation, which occurs in rheumatoid arthritis frequently due to deformities that begin in the wrist and later go out to the fingers. Why there are ways of surgically bringing them back. Before that is done, most surgeons would say that the patient needs an intensive course of medical management by a sophisticated, knowledgeable, probably rheumatologist or some medical person who has advanced expertise in this. And with the current medical management, and I'm hardly an expert on this subject because it's very complicated and has to be done by someone sophisticated. There are a lot of new biologic agents, immune-modifying agents that can help some very severe rheumatoid patients become very functional again. Also, hand surgeons work very, very closely with allied health fields and occupational therapists and physical therapists particularly. We have to coordinate whatever we do with them, because whatever we do at surgery, unlike a lot of surgery, when the glass stitches in, the work is only beginning.
Yeah, surely.
So if you're going to undergo reconstructive surgery of any kind, but particularly in the hand, you need very sophisticated help from allied health professionals who can help in so many ways. There are actually something called CHT, Certified Hand Therapists, in both physical therapy and occupational therapy. And these individuals have advanced training and advanced credentials, and they can take someone with a complex tendon injury that we've sewn together in whatever way we can and help them achieve their maximum function. So the role that they play in this field is even more pivotal than in some ways, other ways.
Yes. Well, you know, when I was a kid, my mom, she used to wash clothes for people, or and she had a scrub board, you know, there was no washing machine, it was a scrub board, and of course, scrubbing like this on a scrub board certainly has a lot of effect upon this wrist here. And of course,
your elbow too.
Elbows too, yes. And the thing was that years later, she started having numbness in her hands, of course, and I would see her rubbing her hands like she was going to try to rub the numbness out, not realizing that she may have this very famous condition that people look like they have in most professions that use the wrist a lot, whether they're shucking oysters or peeling potatoes, whatever, carpal tunnel syndrome. And I would like to, because since time is our enemy, could you just take a little deviation on like carpal tunnel syndrome and what could be done for it?
Well, certainly this is unfortunately a frequent entity, and we see this quite frequently. The median nerve at the wrist is normally in a very tight space,
right,
and there's not a lot of extra room for it. So that if there's swelling due to any reason, it could be, as in your mother's cases, that there was just a lot of hard work that brought on that swelling and irritation around the tendons, and the nerve didn't have a lot of room, so the nerve tends to shut off a little bit or a lot.
Right.
And another time that it occurs is during pregnancy, actually. During pregnancy, there's fluid retention, and that fluid retention can be enough to cause dysfunction in that nerve. And it can cause the kind of numbness that you described for your mother, and it's likely that she had that. Even some arthritis around the wrists, which I'm sure your mother had from all the hard work that she must have done,
right, surely,
can cause enough inflammation there to affect that nerve. And what we do about it depends upon how much it's bothering them and when, and the extent of the dysfunction and the age of the person too.
Right.
So those all go into it. Sometimes we'll see a patient who just has discomfort at night. It's not unusual. They say, I have to get up and it wakes me in the middle of the night and I have to shake my hands, or even stand up, and it's disturbing. They can't sleep. A lot of those patients, it's a postural problem that exaggerates it, and just a night splint for them to wear, if they'll wear it, is enough to improve their symptoms, and they don't require a surgical procedure or anything else done for it.
When you say splint, what do you mean specifically?
Okay, a splint is some rigid structure or semi-rigid structure, even Dr. Deas, that you can readily put on and off your wrist, so they don't have to wear it all day long. If they want to wash their hands, they want to go in the shower, they want to do the dishes, etc. Why? It's mainly, in these patients, it's only bothering them at night while they sleep, so they don't need it during the day. They can function very well during the day, and some of them are very comfortable with that. The other thing about it is, in some people, the symptoms are intermittent, and so they may have it for a few months, and then swelling may go away or decrease. This is particularly true in, say, in pregnancy, would be a temporary problem, a transitional problem, and they may not need anything done. Younger people who require their hands for employment, who don't respond to the splinting, and particularly if we feel that it's becoming more than a sensory problem. You know, the median nerve is a mixed nerve. What I mean by that is there's both motor and sensory fibers in, so that the sensory fibers recover fairly well. They have a better chance of recovering, but the motor fibers, as they tend to shut off, they cause atrophy in some of the small muscles in the hand. When that starts to occur, the muscles don't come back as readily. I used to say that they never came back, but then I saw a few patients that did, where the muscles did come back afterwards. But we would prefer to do something aggressive in those patients before those muscles atrophy and they lose that function in their hand.
When you say motor and sensory,
Yes, sir.
Motor meaning?
Meaning that they are nerves that power muscles,
Right.
whereas sensory just involves feeling and sensation and
Okay.
sensibility, which is very important. Very important, actually. If you don't feel in your hand, you can't protect yourself,
Right.
really, and you don't know where your hand is in space, and it's dysfunction.
Sure.
But that tends to come back a little bit better than motor deficiencies.
What about with the whole new, all these electronic things now? They're using their hands every day on the computers and things like that.
Well, that probably contributes to it. One of the arguable things is if people get involved with the workman's compensation problem, that becomes a legal issue about exactly what its role is in that. And for a while, it was widely accepted this was a workman's compensation problem from people who are doing their hands like that. Now, the Hand Society prefers not to get involved with that, and they use the diagnosis of carpal tunnel syndrome, and they don't get into that etiology so much. And so, but I'm sure that using your hand at least aggravates that somewhat. But you can find in the people who are not heavy hand users too, so that I think involves with a lot of you, it involves the issues involving your personal anatomy, how vulnerable your nerves are, how tight that canal is, and how vulnerable you are, just like you're vulnerable to any other illness or impairment. Why there's differences between you and me and anybody else.
Well, you know, like when you talk about a canal, we say this is a canal, and the nerves are coming through that canal as such. What can relieve some of that pressure other than surgery, or is it just injections into it or things like this?
Well, that's true. What you're suggesting, Dr. Deas, there are sometimes an injection of steroids, cortisone derivatives, can relieve that, and I have seen it help some individuals for a prolonged period of time. Injecting it is not entirely risk-free. Sometimes you inject this medication there, and actually you can make their symptoms worse, and then you don't have a friend then. You had somebody who just goes like this the way your mother did, to somebody who can't sleep at night because of the pain, because you've actually increased the volume around that nerve. But I don't want to dismiss it. I've seen injections be helpful to some people. A lot of the injections, though, are temporary in nature. Some studies have shown 8, 9, 10 months, and then some of the symptoms start to recur. But if somebody feels they don't want to undergo the surgical procedure, or for some reason they can't, or something else, why, it's something that can be done, given the limitations that I've outlined to you now.
And what about the piano players? Concert pianists, for example. You see them with gray hair and all, but they still got this, you know.
I haven't had a lot of those that I've dealt with over the years. I'm sure that some of them have it. I would think that a lot of that has to do with the postures of their wrist rather than their fingers. But I'm sure some of them have suffered from that, but it's not something that I've seen personally.
You know, with the great war injuries, which is now facing our government, facing these young men coming back with all traumatized hands, you know, I imagine. And I know that since, of course, we could go on and on, but just worried about that because time is our enemy here, and time passes so fast that I know you could come back here 100 times and discuss all these things, but just maybe just a brief moment on hand injuries and war.
These are very tragic, obviously. People lose digits, portions of the hand, sometimes the full hand. Not only that, but the problem is there's sometimes enormous scarring about the hands that come from these blast injuries. So the tendons require very smooth areas to function normally so that they glide back and forth so that people can open and close their fingers and their hands. And a lot of this is severely damaged by some of these war injuries. So compromises have to be made about what we can do. And again, there's a big cosmetic issue. Now we have a lot of women in the services, many of them who are exposed to in harm's way, actually, and they end up with serious injuries as well, even amputations, and the cosmetic aspects of that, as well as the functional aspect, become very important.
Well, Dr. Gordon, I'm going to take your hand because you're going to have to come back and give us some more information on the hand. And to you folks out there, I hope you got a handful of information today, but you got to have much more because have Dr. Gordon to come back. So we'll see you the next time. Lend a hand when you can.